Assalamu alaikum. My name is Dr. Asayed Asif Razadi. I welcome you all on a special podcast on 25th conference of Pakistan Society of Hepatology. And today we are talking about on metabolic dysfunction associated steatotic liver disease and its nomenclature. Today our guest, Dr. Muhammad Salih. He is an honorable guest. He is my teacher as well as my mentor. I welcome you, sir. And we need to talk about the prevalence and the epidemiology in Pakistan and about the nomenclature of steatotic liver disease in Pakistan.
Thank you, Asif. It is the steatotic liver disease, as the name suggests, and specifically metabolic dysfunction associated steatotic liver disease. This means that there are some metabolic dysfunctions in the body, along with the deposition of fats in the liver and leading to the liver damage. Now, you asked specifically about the prevalence and epidemiology. So the exact prevalence and epidemiology, which is a community-based data, is not available. However, one can extrapolate data, and the fatty liver disease prevalence can be more than 1/3 of all our patients or even community. And then there are at-risk populations like the one who had cardiometabolic syndromes or with diabetes. These are specifically at-risk population. And even with simple looking at the body habitus, we also need to understand one thing, that our body mass index for this region is different than the one mentioned for the Europe or Caucasia. And which means that it's the upper limit is 22.9 for us, and beyond that till 24.9 is overweight, and then it is obesity. And we don't have grade 3 in morbid obesity. For us, grade 2 is that. So once your BMI crosses 30, then you are having an obesity or morbid obesity. The other thing important is that there is another term which we usually see, that the patient BMI may be normal, but still they would have steatosis in the liver. And that is basically NOFL or non-obese fatty liver disease. And unfortunately, this is more common, and we have now some insight, recent publications by Professor Zagham Abbas, which showed that there are some PNPLA and other mutations, genetic mutations, or available or in this population, specifically in our country, that would lead to accumulation of fats. You also asked about one more thing, that's about the new nomenclatures. So previously we would call it non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. So there was stigmata of this alcohol use when it was not there. Now they call it metabolic dysfunction associated, because it's not only one thing, it's the other organs of the bodies are also involved, because cardiometabolic is rather to be very inclusive of everything. We would say it's hepatocardiometabolic rather, because kidneys are also involved, cardiovascular system is involved, cerebrovascular is involved, and everything else is involved along with the diabetes and hypertension. So we move from one spectrum to another one. So if the person is not consuming significant amount of alcohol, then we call it metabolic dysfunction associated liver disease. But if the person is consuming alcohol but in less amount, so we call it MASLD, which is both combination of that, and at the other extreme there is an alcoholic liver disease when the person is consuming significant amount of alcohol. One more thing is that steatotic liver disease, in addition to the metabolic dysfunction and alcohol, can be another disease like even simple hepatitis C presenting with liver steatosis.
So we need to exclude all.
Of course, you need to, because these patients are not immune to any other diseases, one. Second, even in Wilson disease, some other metabolic conditions like Wilson disease would have it, drug-induced and then cryptogenic steatosis. So now it has become a spectrum of steatotic liver disease, and in that, when the other things are ruled out, including the amount of the use of alcohol, then we call it metabolic dysfunction associated steatotic liver disease.
Sir, thank you very much. What is the perspective from the as a simple gastroenterologist point of view? What are the parameters for which helps diagnose the disease?
Look, like we say that every person, like 1/3 of population, if we just can say it like that for simplicity, of Pakistani adult population is with diabetes. And we also know that 72% of these patients would have fatty liver disease. So you can imagine that how prevalent this disease can be. One. Second, by just one more thing is, if you look at a BMI, one can predict that what will be that. And even simpler than that, even your collar size or your waist size or waist to hip ratio can be predictive of how, like what you are dealing with. So any person who has got one cardiometabolic risk factor, and if a fatty liver is there, then this is called metabolic dysfunction associated steatotic liver disease.
And sir, how will you define the first lifestyle modification? What are these? Are the first line of therapy with the metabolic disease for the?
Of course, this is the only cornerstone and the only proven thing which you need to have. Even a 3% weight loss can have some effect on that, reducing steatosis, followed by 5% balloon degeneration, reduction in that, and then you move on to the resolution of the inflammation, and then if one achieves a 10% weight loss and above, then there is regression of the fibrosis. So it's basically what you need to have is to have a reduction in your body weight. And the primary and the main thing would be lifestyle changes, dietary changes, because unfortunately our staple diet is mainly carbohydrate based and sweets, all sugars in all form and juices and these things. And to top it up, now we also have these fast foods chains available all over, and to my surprise, even in villages they now deliver.
Yes, they are delivering day and night.
They are delivering that. Yeah. So it's basically in the fast food that S is silent. It's fat food.
Right.
So it's not a fast food, it's a fat food. So because the combination and the composition of that meal is not appropriate.
So sir, what's, just a learner, what is our concept of junk food? Is it really the food which is coming from the market? Is it called junk food, or the junk food we can make at home? What is the junk food? Can you please elaborate the junk food?
Well, junk food are processed or ultra processed foods. I'll tell you a simpler definition. Whatever is not available in your kitchen, and if the food is having that ingredient, can be categorized as a processed food. And that's simple. Right. Because the processed food, ultra processed foods, because these things are not good for our health. The simpler our own foods, they are helpful. And other main thing is that we do not now move. So someone once asked me that does fatty liver runs in family? I said, well, it's probably the family doesn't run. So it's the main thing is the activity.
Right.
And it's not only your total body mass, it's the compositions of fats to the muscles. Right. So you may have a normal body mass, but you may still be sarcopenic, which means less amount of muscles in comparison to the body composition.
So just questions arrive in my mind. If somebody is a bodybuilder and is having more muscle mass, is BMI is okay to gadget? Is BMI is a good gadget for a person who is having more muscle mass and who is not?
So there's the main issue. So if you look at the people who are fit, they would have maybe their BMI may be in the overweight category, or even upfront on the face of it, they may look like a grade 1 obesity. But if you look at their waist to hip ratio, it will be good.
Yeah.
If you just look at their waist circumference, it will be good. So it's not only one thing, and that's why there's a flaws in this inbuilt flaws in the BMI, because it measures the whole sum. It's just like a mixed mithai or mixed sweets combination of 1 kilo And 1 kilo is 1 kilo, but how much burfi, other things, gulab jamun, rasgulla you have, you don't know. So it's 1 kilo will be 1 kilo. But and other thing is that muscle is the heaviest of all the body composition things. It's heavier than water, it's heavier than bones, and it's heavier than the fats, of course, much, much heavier than that. So if you've got fats, like the bulk does not correlate with the exact weight of that. And it's not only the fat, where do you have that fat? That fat. It's more important. It's a visceral fat, it's around your waist, or it's somewhere else. So at times you may see patients or persons who would have a high BMI, but their liver is not fatty because their body fat composition or distribution is in appropriate areas rather than around the waist. So it's basically, you need to have it as a central obesity, which is mainly predictive of the fat in the liver, and so is the metabolic dysfunction associated steatotic liver disease.
Sir, so what are the pharmacological options available to treat MASLD in Pakistan in 2025?
Look, there are a few things. All patients with fatty liver disease should be screened for diabetes, should be screened for other cardiometabolic risk factors. Now, if they are dyslipidemic, you need to work on that. Okay, and you also need to know where their total cholesterol is high, or it's the LDL cholesterol which is high, or even the HDL cholesterol which is low is also risk factors. And then you need to look at the triglycerides. And accordingly, you need to first try to modify their diet. Once you modify their diet, along with exercise, you wait for that for 3 months or so. And then if they still would have a dyslipidemia, then you may add an anti-triglyceride agents or a statins or a combination. It depends then. So it's true for the diabetes. Now, if a person who is a pre-diabetic or a diabetic and having a fatty liver disease, your approach is different than a non-diabetic. Now, like insulin resistance is there in the fatty liver disease, and then you need to address, and then there are medications like the metformin for that sake, which works. Then there are these new SGLT2 inhibitors, which works. So you need to select your agents according to the presence or absence of other diseases, like whether diabetes is there or not, or if the patient is a pre-diabetic or he is a non-diabetic. And then according to, having said that, even in non-diabetic, there are medications which will work, like the simpler pioglitazole, which will work, even vitamin E for that matter. A caution should be made that how much vitamin E we should give and for how long, because there are some relatively risks associated with the vitamin E as well.
Like cerebral bleed and
intracranial hemorrhages or hemorrhagic stroke, as well as prostatic CA, which are there, but it's not like an absolute thing. And then the other thing is that how much you give, then whether you are giving synthetic vitamin E or not, it's also important, and how much you should give. So the routine one, which is pharmacologically or pharmaceutical wise available, I think a 400 milligram of vitamin E is what you need to take.
All right. So tell us about GLP-1 and the combination of GLP and GIP.
Yes, now we have drugs available, specifically like now there are some things which are available for weight loss, and then there are some available for both. Now, all these three things, like the GLP, GIP-1 inhibitors or receptor antagonists, or the GLP alone, the dual or a single one, or the newer resmetirom. So they all work. You need to select patient as well. They're not for everyone. You also need to look at their history. You screen them for thyroid diseases. You also screen them, or you listen to them what other medications they are taking, like statin. If they are taking, you need to adjust the doses of resmetirom.
Increases.
And then there are specific indications for that. Like if they've got steatotic disease-associated cirrhosis already, then you are not giving
You are
them.
not giving it.
They are basically for significant fibrosis, F2, F3, along with that. And so is but the other one can still be given for these, to these patients, because which will decrease the weight as well as will improve the steatosis.
Sir, one is a practical question coming into my mind. When we do FIB4 and fibroscans and we start the therapy with the drug resmetirom, with the next visit, the patient's ALT and AST goes up. How you say, what are your comments on that? Because this is the real concern of the patient, that my liver function tests were slightly better, then you have to start the therapy. And second question is, how much patients you have seen that they have decompensated with when we start the resmetirom in the later stages of the metabolic patient?
So your second question first, how much I have seen? Look, it depends when you started these medications, were the indication correct or not? So if you start them with F2, F3, then you are safe. But if you're starting with advanced fibrosis or F4, which is cirrhosis or so, then yes, they would decompensate. So you need to select your patient properly. Right. One. Second, when you start them on these medications, specifically resmetirom, the ALT-ST would go up. Now, these are not going to work in days and weeks. You need to wait for months.
Right.
So and you are not doing after 1 month or 2 months their fibroscans or other things, because they're not going to improve. So you need to wait for 6 months minimum, if not a year, before you decide. And of course, you ask them to, when we call them for these routine follow-ups, we are looking at the side effects or the tolerability of these drugs, because if something is happening, you need to work. And even with GLP, I have seen patients whose LT have gone up, and you need to monitor these patients accordingly. And then you need to look at because there are some side effects of these medication, including depression, including the pancreatitis, but they are not like I would say, because now they are being in the market since long. The first generation and second generation, the GLP-1 inhibitors, and now there is availability of the oral one will be soon available to us. So from injectable to the oral, we make
it's my take. I may be wrong. When we give oral peptides, any protein or hormone substance, is it safe to give oral like semaglutide orally? Because my thinking is there are lots of hydrochloric acid inside the stomach, and you see when we give semaglutide subcutaneously, we give weekly very lower doses,
and then you increase.
And then on the other hand, you see oral drugs, they start with 3 milligram minimum. So my take is, might be all 2.5 milligram is wasted and only 0.5 milligram is absorbed with when you give 3 milligram dose. What is your take with the oral medicines?
So look, whenever these molecules are tested, first their dose finding studies are done, that at what dose they are effective.
Right.
Then they are formulated to interform to avoid degradation and breakdown by enzymes and the acids. So, and where do you want them to act?
Yeah.
Okay. So that's the main thing, and that's how it works. Okay. So the effective dose is not like the oral dose directly converted into a subcutaneous dose. So it's basically the effective dosage once they do these before the phase 3 trials, the dose finding studies of these medications. So their efficacy initially, their safety and dose finding studies are first done, and then the rest of things, or the phase 3 study would come in. So if phase 1, their safety, and then the dose finding studies are first performed, and then they come into the efficacy study would follow. And then of course, even after that, we have seen molecules like once they were approved have been taken back, or there have been warnings.
Just like liraglutide and
there are so many other medications for that matter. So they have been withdrawn because post-marketing surveillance is still there. That's why we call it a scientific medicine, rather than once we have said something, it works, it works. No. If there are better molecule available, one, they are cheaper, easily accessible, or easily given. So we move to that. Or on the other hand, if they are working, but there are significant complications or side effects of these medications, then you need to look to other molecules rather than continuing with the SAM.
In the last, I would like you to give message. Would you like to treat these patients alone, or you want to treat this patient with your team, like endocrinologist, cardiologist, and the gastroenterologist, hepatologist? So what is your message for the PGs or the GPs, those who are watching our channel?
Look, all these patients, I would say that there are some patients, like the initial stages, a GP or a medical specialist even can take care of them. However, by applying these FIB4, etc., or the activity index, one can categorize them whether the primary care physician should be dealing with them or they should be referred. Like if their FIB4 is more than 1.3, for simplicity we can say 1.5 and above should be referred to a specialist care. Reason being that they are better at these handling these patients, because they are well versed with, probably because this is their daily routines. The other thing is that all these patients is hepatocardiometabolic. It's the whole body. It's not one organ that I'm dealing with this. No, you need to rule them out. The cardiologist, the endocrinologist, and so is even rehab. So is the importance of a nutritionist or dietitian. They are important as well. Then you need to also, the other thing which we usually would follow and we usually say is take this diet. But is that diet available in Pakistan? Is it affordable to take?
Yeah.
It's very easy to say a Mediterranean diet,
Yeah.
but like how? Is fish that cheap?
Yeah.
Okay, is olive oil that cheap? And even I would say that probably we need to work in our own setup. Why not mustard oil?
Right.
Because it's
freely available and very cheaper.
It's relatively cheaper one.
Yes, relatively cheaper.
So why not mustard oil and other thing? The only one thing is that it's basically the balance. I usually tell my patients that one bite which you take extra is being deposited in the fat form.
Right.
So you need to take whatever is needed. Some would say, I only take meals twice. But if you're not exercising, if you're not doing something which requires calories, like a person who is working in the fields can take maybe 6 chapati.
Right.
But the person who goes to the office, usually on a bike or in a vehicle or public transport or their own transport, when they are not exercising, they are not burning their calories, then we also need to say one more thing, is that healthy lifestyle is not only medications, not only exercise, it's not only the diet, it's the combination. And you need to spend around 5 minutes or so. The other thing is that we are also at times pretty much fixed in our ideas. We are not good at predicting at times what may suit one of my patients may not suit another one.
Yes.
So you need to modify these things, and probably that's why a multidisciplinary approach is required. You need to send them. I would through this opportunity, I would ask my all nutritionists and dietitian as well that they should direct or advise their patients according to our situation, rather than half cup of that and half cup of this and that. So we need to say that. So for simplicity, if you are taking complex carbohydrate like vegetables, fruits, you are not taking juices, because when you take juices, majority of time you are only taking fruit sugars. We are only taking fruit sugars. We are not the roughage and all that fibers and other things, they are left behind. You are not taking those. And that's why whenever you take these things, then there is a surge of glucose in the body. The insulin response, it takes care of it, deposits it somewhere in, and then it goes down. And then you have these cravings. So you need to take meals in a way that it's filling effect is more, along with calories, and everybody has got a different calorie. If you are doing exercise and if you're burning 5,000 calories may be okay with you, but if you are not, probably 2,000 may be more for you. So you need to calculate, you need to spend time yourself or refer them to another person who is better at calculating these things, modifying diets for or looking at their special needs.
Well, thank you very much, Professor Saleh. It's really an honor for me to interview you. Thank you very much, Ferozans, for giving us an opportunity to talk on a special topic with Professor Saleh. So thank you very much.
Thank you.
Thank you.
Thank you so much.
Thank you.